Professors, let's talk about antibiotics, okay? So, in my mind, when I think about antibiotics, I always divide it into MRSA, Pseudomonas, non-MRSA, gram-positive, and non-MRSA, Pseudomonas, and anaerobes and others, right? So let's talk about anaerobes quickly. So what covers anaerobes, the most important ones? All right, what covers anaerobes? It's gonna be flagell, we know that, right? Flagell metronidazole, right? It's gonna be clindamycin. All right, and these are the main two that cover anaerobes. There's others that I'm gonna put them on the side that cover anaerobes, but they're not mainly for anaerobes. These two are like kind of the big guns for anaerobes, right? But there are a few others like Zosyn, right? Zosyn is piperacillin, right? All the carbapenems, which is like imipenem, imipenem, meropenems, doripenem, and ertapenem. All of those cover anaerobes. Unicin, which is ampicillin, sulbactam, right? That's unicin. And there's another one called ampicillin. Clavulinate, which is augmentin. So this is augmentin. And this is unicin. One is IV, one is PO, but they both cover anaerobes, right? There's so many antibiotics. Cefoxitin cover anaerobes. Cefotitan cover anaerobes. What else? Yeah, we can stop here, but there's so many that cover a lot that cover anaerobes. But these are the ones that we would think about when we say, okay, we need to cover anaerobes now, as we're covering other things, right? But flagell has an advantage over all of them because it's very, very strong against bacteroides. Right, so sometimes you see the surgeons specifically saying after abdominal cases when there's like a gallbladder necrosis or something like that, or maybe a bad perforated viscous or something like that, they put the patient on Zosyn and flagell together. Right? It's like, what are you doing? This is some bacteroides, which is a gram-negative anaerobe, right? Some of them are not covered by Zosyn and they have to be covered by flagell, right? Clindamycin has another advantage over the others because it has also like toxin inhibition, production. So they're basically for gas gangrene and stuff like that. Clindamycin is a way to go because it prevents the toxins from producing. So it doesn't only, we're not interested in just killing the bacteria in this situation because the bacteria is full of toxin, it dies. Toxin will be all over the place. So we're interested in inhibiting the toxin as well. So whatever you treat gas gangrene with or necrotizing fasciitis or things like this, you treat it, but you have to add a couple of days of clindamycin. Okay? So that's your anaerobes, okay? Let's talk about MRSA, right? So antibiotics that kill MRSA specifically. And we're gonna start with vancomycin, obviously, right? Linezolid, daptomycin, ceftaroline, and doxycycline and Bactrim, right? So we can look at them this way. So which ones of those are bacteriostatic and which ones are bactericidal? So this one is static, vancomycin. Linezolid is static. So you know the difference between static and cidal, right? Static it doesn't kill the organism, just it prevents the growth. Daptomycin is cidal. Ceftaroline is cidal, and these two are static. Okay. There's something specific about these two that I'm gonna just say it out here because there's a lot of confusion among our colleagues everywhere. These are not meant to treat in-hospital MRSA. This is outpatient MRSA. So they actually inpatient MRSA have a different genotype than outpatient MRSA. So they can't treat outpatient MRSA. They've never been treated, never been tested in a study to show that it actually is as good as Vanco or something in the treatment of outpatient MRSA. So don't try to use them here. All right, now linezolid, the advantage is it can be given PO, but it also can be given IV and it's the same dose. These two are daptomycin and ceftaroline and Vanco, obviously they're all IV. Which one of them is great for the lung penetration? It's the best for lung penetration. Linezolid, number one. Vanco is mediocre for lung penetration. Daptomycin, no lung penetration whatsoever. It's deactivated by surfactant. So if you have somebody with MRSA in the blood and the source is the lung, you can't use daptomycin. It's not gonna work, right, in the lung. Which one of them is the best for bacteremia? The best for bacteremia is daptomycin. And I'm comparing these three together. I'm not comparing ceftaroline yet because it's just so expensive and so restricted that you're not gonna find it in, we're gonna talk about it by itself. But daptomycin covers bacteremia very well, right? Linezolid is the worst for bacteremia. You don't wanna use this for endocarditis. It's bacteriostatic. It's just so mild. It's not so mild. It has good penetrations in different areas, and it kills MRSA, but it just takes a longer time. So you can't use it for bacteremia. And Vanco is also mediocre, right? For bacteremia. So if you have a choice in bacteremia, daptomycin is the way to go, more than Vanco, obviously, right? So what else? Soft tissue. So which one is good for soft tissue infection? Linezolid is the best. Daptomycin is second, and Vanco is the third. Is like I'm gonna say for soft tissue infection, right? Because Vanco has less lung penetration than linezolid, right? So it's the second in lung penetration. That's why it used to be that the dose here is 10 to 15. The trough level. The trough for the lung is 15 to 20. Has to be higher a little bit, but now everything is 15 to 20, just so it doesn't cause confusion. Everybody's 15 to 20. And by the way, Vanco, just to specific things about each antibiotic. Vanco, it's debatable whether it injures the kidneys or not. I think it does injure the kidney when the trough is too high, right? But it's not like 22, 25, 30. It's usually much higher than that. So now it is actually the standard of care. I don't know how. I'm not aware of a single hospital that does it, but it was announced by the IDSA, the American, the Infectious Disease Society of America or something, and the American Thoracic Society, both of them said that the best way to regulate vanco dosing is to do the area under the curve. It's the AUC, not the particular level. So how much is that level, and then using a computer algorithm and finding out what's, how much is that area under the curve, and that's what kills the organism basically. They said this is the best, and it didn't result in as much renal failure and had much better outcome when it comes to killing organisms and stuff. Cifterolene is good for the lung, is probably as good as linezolid for the lungs. It's great for bacteremia, and it's great for soft tissue. So it's like literally number one in all of those. But it's so so restrictive, just because of the expense and stuff like that. Now we're gonna add something here important, which is what? So MRSA is methicillin-resistant Staph aureus. We're gonna add VRE here. We're gonna say, what kills VRE out of those? So VRE by definition is called a vancomycin-resistant enterococcus. Not enterobacter, enterococcus, right? It's a gram-positive. Vancomycin-resistant enterococcus. And obviously vanco doesn't kill it because it's called vancomycin-resistant, right? Linezolid is great, and this one is great as well. These three can kill VRE. These ones don't kill VRE, right? So that's important to know. When every antibiotic we're gonna write the same like this. By the way, there's also one thing I want to tell you for vanco MIC. So the MIC is minimum inhibitory concentration of the antibiotic. You can't compare MICs of two different antibiotics to each other, and you can't compare MICs of an antibiotic on a certain organ, different. We can't compare it to each other. You have to compare it within the same antibiotic itself. Like MRSA for this organism, the MIC is 1, good. For this organism, the MIC is 2, bad. Stuff like that. Within the same antibiotic itself. So there are a couple of things about that. The vanco, most labs, they cut. So it depends where they cut, right? They keep diluting, and they find that the minimum inhibitory concentration is X. And then they decide by themselves, depending on what percentage of colonies are killed, they say, okay, well, this amount of colonies are killed, so that means that we're gonna consider this sensitive to vanco. Well, how about the 10% that wasn't killed? Well, it's good enough. We killed 90% of the colonies. So depending on where you set your level, how much you're comfortable with that it's not being killed by the organism, right? So this is a debate that they're saying that vanco, when it comes to MRSA, the ideal when you go above 1.5 MIC, right? 1.5 and 2 MICs, the vanco only kills 15% of the colonies. So, but they still consider it sensitive to vanco, right? So what I do in our practice here is that we say, okay, if I have somebody with a severe infection like bacteremia or severe lung infection, patient is very, very sick or whatever, if I go above 1, if I see any MIC above 1 on the vanco, why would I play with that game? I have this and this, and why would I play that game? I have other options. It's not like in the past we had to kind of pretend that the vanco was working, right? So above 1 for severe infection, don't use it. Although the lab is going to say it's working. So this is what we're going to do every time we see an organism. It's a little annoying, but you'll see why I'm doing this. This is MRSA. This is Pseudomonas. This is gram-positive other than MRSA, and this is gram-negative other than Pseudomonas. And then outside of that, we'll write other things. So, for example, what does vanco cover? It covers MRSA and gram-positive. Doesn't cover any gram-negative, right? Linezolid. The key in this lecture is how fast I draw this. Because I'm going to draw it like 15 times. MVRE. Right? These ones here, I'm gonna say the Bactrim, for example. I hate to compare them to those, but you know, we'll compare them anyway, just so you know and get the idea. Bactrim covers a lot of other things. I'm gonna say, Bactrim, it covers all the gram negatives basically, so it covers all of those. And covers PCP too, right? Doxycycline, it covers a lot of other things as well, you know, but not gram negatives, gram positive, gram negative. So it covers gram positive, outpatient MRSA, but it covers atypicals, right? Right, like mycoplasma and stuff like that. Okay, so we're done with gram positive. Let's talk about MRSA. We're done with MRSA. Sorry. Let's talk about Pseudomonas. So what covers Pseudomonas? All right. So the classes are a lot. So basically, first we have
aminoglycosides.
Yeah. So let's start with aminoglycosides. Okay. What are those? These are gentamicin, tobramycin, and amikacin. Okay. Next, we're gonna say third generation penicillins. Like what? Like Zosyn. It used to be something. Remember ticarcellin? It died. Anyway,
Zosyn.
And then we have third generation cephalosporins, but not all of them. So I'm going to say partially, not all of them. The only one from the third generation cephalosporins that covered is ceftaz. And then fourth generation cephalosporin, and that's cefepime. Okay, and there's fifth generation cephalosporin. Actually, you know what? This is very rare. I'm not going to write it down. Let's write the important stuff first. Right? Then we have carbapenems, which is what? And not all of them, by the way. I'm going to say partially too. And like what? Meropenem, imipenem, and doripenem. Okay? And we're going to say there is monobactam. Monobactam is only one thing only that we know is aztreonam. And then we have fluoroquinolones, which is what? Not all of them, partially. Levofloxacin and ciprofloxacin. Okay? So let's see. This is gonna be important to draw those. I wish I have a stamp like the people who,
Right.
the revolution people in the street. Quick. All right, so gram positive, sorry, MRSA, gram positive, Pseudomonas, gram negative, MRSA, Pseudomonas, gram positive, gram negative, gram negative, gram way, there's a whole kind of outpatient antibiotics that I'm not even writing here. The whole PO stuff and that doesn't help me. All right, so aminoglycoside, it kills all of the MRSA, Pseudomonas, and all of the gram negatives. They're very strong. They're bactericidal. And it has a kidney effect, right? It affects the kidneys. There were two doses available for the aminoglycosides, which is the 1 milligram per kilogram Q8 hours versus 5 milligram per kilogram Q24 hours. And this is what we call they are. So basically, the way they kill it is so potent against the cell wall, right? So it makes a hole into the cell wall, and basically, the higher the level of the aminoglycosides above the MIC. So if you have the MIC here, this is the minimum alveolar concentration, minimum inhibitory concentration. Goes like this, right? So it goes above the MIC. So because it kills with the height of this wave, the higher it is, the more killing it will. I call it the bazooka. This is basically the bazooka of the RBJ of antibiotics. It just kills by immediately, and it kills the human cells. It kills the bacteria. It kills everything. It just clears the playing field and starts from the beginning. Okay, so that's why it was even used for decades as a conjunct to vancomycin in the treatment of MRSA endocarditis. What? Doesn't kill MRSA, but it just for some reason it makes holes in their walls as well in a higher concentration. So because of the peak of aminoglycosides, that's what determines the killing. The trough of aminoglycosides is what determines the toxicity. So that's why people moved away from the 1 milligram per kilogram 3 times a day, because you are increasing your chances of having a problem with the trough. The trough is supposed to be less than 2, for example, for gentamicin, right? But they moved into this dosing here, which is once daily dosing. Is much easier. You give a huge dose, it gives you a bigger peak, right? Because you're concentrating everything in the beginning. The rest of the time, of the whole day, after the first hour, you're below the MIC for the whole time. So chances are your trough is going to be very good tomorrow, and you're not going to injure the kidney. So in our practice, what we do, obviously we don't use this all the time, but we use it for certain things. You know, people who are gram-negative bacteremia. It was found that if you actually miss the treatment, if the first antibiotic dose missed the organism for bacteremia, your mortality rate goes from 20 to 80%. Like, it's a killer. It's like the worst thing you can do for a patient is to miss the first dose of antibiotic. So somebody who's cavalier, and I've seen so many of those.
So miss within what period of time, just to clarify?
Oh, the first day.
First day,
Like you didn't
first
give
24 hours.
First 24 hours. Yeah.
Okay.
So in the first 24 hours, you couldn't find that's huge. I mean, but 1 hour,
Yeah.
it just increases by 7% or whatever.
The mortality rate for each
Yeah.
hour after diagnosis.
Yeah, it increases by 7 to 9%.
From the basis of the serum lactate.
Exactly.
Okay.
So this one, if you miss it for 24 hours, increases the mortality huge. So we don't want to do that. So if you have a UTI, many times you have a UTI in somebody who's a nursing home patient, and you say, ceftriaxone. Okay, you missed it. If it's a UTI, it's okay to use ceftriaxone, but if it's a bacteremia, from the time you found out that it's bacteremia, if you actually missed it, it's a big deal. So that's why when we see somebody that has signs of bacteremia, we give him gentamicin, 1 dose. 1 dose doesn't have a trough. What's the trough of 1 dose? 0. The trough is the end, there's nothing. So that's why we give it. So if we find the bacteremia, reach for the genta, gram-negative bacteremia. Another modification is that if you find that you have severe gram-negative infection by finding that you have procalcitonin more than 20, procalcitonin more than 10, there is 96% chance that you have gram-negative bacteremia.
Greater than 10.
Greater than 10. So we moved it a little bit. I said, okay, well, it's greater than 20. We are gonna stop the vanco, and we're gonna give 1 dose of gentamicin. By the way, if you have gram-positive bacteremia, we give daptomycin, 1 dose. You can continue on the vanco, but 1 dose, guaranteed, cidal, it kills everything. Same thing, kills everything, gives you a great advantage for your patients, okay? So that's that. Now, 3rd generation penicillins, that's Zosyn, right? Zosyn kills what? It kills all the gram-positives, and all of them, Pseudomonas, and all of the gram-negative. It's amazing. It's only missing MRSA, and obviously VRE and the weird things that we put outside, okay? All right, how about 3rd generation cephalosporins, the ceftaz? That's the only one of the 3rd generation cephalosporins that kills Pseudomonas. Ceftaz. Ceftaz kills what? Pseudomonas, very effective, and gram-negatives. But it has no effect against gram-positives, right? In fact, I got cited, or we got cited by a long time ago, like 20 years ago, when there was actually, there was something called core measures. You know, they have to treat HAP in certain ways or whatever. So they say for HAP, I didn't understand the statement. The statement said you have to use, for HAP, you have to use anti-pseudomonal, anti-pneumococcal antibody. Antibiotic. Anti-pseudomonal, anti-pneumococcal antibiotic. So I said, okay, we'll use ceftaz. Ceftaz is not anti-pneumococcal. It kills only 14% of the colonies of pneumococcus. So obviously, it's not suitable. Because what's the most common bacteria for any pneumonia, including HAPs? Pneumococcus. Pneumococcus is the most common bacteria in any pneumonia, in hospital, out of hospital. So that's why this is not suitable. And there is a practice that is happening right now, unfortunately. I see it happen everywhere now. This is like literally shooting the patient in the head. It's unbelievable, you know. There's some hospitals that are still stuck to ceftaz, which is fine. Think about it this way: if you have vanco ceftaz to start on your patients for HAP, right? You want to cover everything. So you have vanco here covering those, ceftaz covering those. You're covered. Everything is fine, unless it's like weird organism, right? So the problem here is that if you vanco is bactericidal, bacteriostatic. Ceftaz is bactericidal, so you are doing a good job with the gram negatives, but the gram positive is bacteriostatic. You know, it's slow, right? That's fine. I mean, this is just semantics, but I think it's better to start to use something like cefepime or Zosyn that can kill gram positives, which includes pneumococcus here, as a cidal organism, and you're only adding vanco to overlap with this a little bit and to kill MRSA, to cover MRSA. So that will give you a better bang for your buck. You already killed the organism that is most common, right? But let's say we insist on doing vanco ceftaz for cost and for everything else. Okay, fine, vanco ceftaz. What do we do now for MRSA in the lung pneumonia? What do we do? MRSA swab, right? For some reason, I hate this study. I have to use it because it's out there. So I do MRSA swab and I stop the vanco like everybody else. But I just hate it because it flies in my face because just 2 years before that study, there was another study that showed exactly the opposite. But it wasn't as famous. Why wasn't it as famous? Because it wasn't convenient. The other study showed that if you do MRSA swab on people, there's no correlation between if they have MRSA in the lung or not. Okay, so we took that. 2 years later, it became, there's a lot of correlation between this and the lung. So now we stopped them with the MRSA. That's the vanco. So because it's just convenient, that's where the country wants to go. We're gonna take that study. Fine, we took the study and we stopped the vanco. When you stop the vanco on people who don't have MRSA in their sputum, what are you left with if you're using ceftaz? Gram negative. You're still not covering Pseudomonas, pneumococcus at all. That's dangerous, and I've seen it happen by ID doctors all over the place. They don't cover pneumococcus anymore. That's dangerous. Anyway, I've seen also people just taking the study beyond. This is like the stupid people, not the ID doctor. This is like the real stupid people. Took the study and said, there's no MRSA in the nose. I'm treating cellulitis. Then I'm going to stop the vanco. What is the MRSA in the nose that's doing cellulitis? It wasn't studied. Okay, now let's say fourth generation cephalosporins. Okay, they cover the cefepime, right? Cefepime covers Pseudomonas and gram negative, and also gram positives. So it's similar to Zosyn. I'm sorry, I forgot to say that Zosyn cover anaerobes as well. Right? We said that over there. Right? This one is exactly like Zosyn but doesn't cover anaerobes. How about carbapenems, meropenem, imipenem, and doripenem? They cover this. Pseudomonas, they cover gram negative, they cover gram positive, and they cover anaerobes as well. And they cover what? They cover a slew of other things that that we don't. So there's something called. So when it comes to penicillin, there's something called beta lactamase. Right? Beta lactamase is just a simple thing. It just kills penicillin. This is something the bacteria makes that breaks down penicillin only. So having beta lactamase positive, we do that for the mediocre organisms like Moraxella, Cataralis, right? It infects COPD patients. We do it for, like we test it for, Haemophilus, to see if it's beta lactamase positive, which means don't use penicillin. Who's going to use penicillin these days? But yeah, if you're in a place that uses penicillin all the time, yeah, fine.
You
But
could use anapcillin for endocarditis.
yeah, definitely, yeah. But I'm just talking about, the beta lactamase, right? So
Okay.
nafcillin will work.
Right.
Anything other than penicillin, even amoxicillin will work for those people, for those organisms, right? That's if it's beta lactamase. But look at this. Extended spectrum beta lactamase. That's the one that kills all of the penicillins and all of the cephalosporins, right? That breaks down all of these antibiotics. So that's huge. These are we call ESBL. So the only one that we can use for ESBL is carbapenem, right? So if ESBL is there, then this will kill it, and aminoglycosides. I'm gonna write here it kills ESBLs as well. Right.
I know.
What?
Like during my med school,
Mhm.
during my oral exam,
Mhm.
they asked me like, in sepsis, like what do you give for gram negative? I said cefepime.
Mm.
They said no, meropenem. Then
Oh,
like
that's
meropenem.
that's very progressive. Okay. All right. So ESBL. Some people call ESBL MDRO. I don't know why they changed it, but MDRO, multi-drug resistant organism. Every time we try to understand something, and the ID people think that we understand them now, they change they change something quickly, so we think that we don't understand it. All right. Aztreonam. Aztreonam kills these two only. So what is Aztreonam? So Pseudomonas and gram negative. It's similar exactly to Ceftaz. It's exactly like Ceftaz, and also it's a cidal antibiotic and everything. This is high, Zosyn. It's a fifth. Sorry, did I say fifth generation penicillin? It's actually unrelated to penicillin, so you can use it for patients with penicillin allergy. But there is a high cross reactivity here. Third generation cephalosporin, much less reactivity with penicillin, probably less than 5%. Fourth generation, much less. Even carbapenem has some relation to penicillin, but it doesn't really, very, very rare. And then monobactams, like less than 1% reaction, cross-reactivity with penicillin. Now, fluoroquinolones, levofloxacin and ciprofloxacin. It kills. Oh, I want to say one thing is that this is rare to be used organism. Antibiotic as Aztreonam. So that's why it preserves some of its function for Pseudomonas. So if you have something somebody that is really still, the procalcitonin is going up, and you start at cefepime or something, whatever, it's worth to try to switch to Aztreonam. Based on the usage of antibiotics and the antibiogram in your hospital, they might find that Aztreonam is working where cefepime is not working. Although they work both on Pseudomonas, but the resistance develop all the time, right? So fluoroquinolones, it kills all of Pseudomonas, and it kills of gram negative too. But also, it kills all of the gram positives. And also, it kills atypicals. Right? So it's very good for atypicals like Legionella and all of these things you can use fluoroquinolones for. The good thing about them, both of them can be given PO. Levofloxacin and ciprofloxacin, both of them can be given PO. It's the same dose, same bioavailability. The doses differ. If you want to use levofloxacin for Pseudomonas, you gotta use the 750 dose as opposed to the 500 dose. So it depends. It's affected by the kidney function, so you have to regulate it based on the patient's kidney function and all of these things. Okay, so that's your thing. Now we're gonna mention a couple of those that are rare but new, and we have to think about them. So basically, you know that we reached to 4th generation cephalosporins, right? There is a 5th generation cephalosporin. It's called cefdericold, and that is, I'll show you what it kills. It kills everything, but it kills something that is becoming a problem recently. So Pseudomonas gram-negative, MRSA gram-positive, and then so it kills those, right? But also CRE. So this is an organism that were developed because of the use of antibiotics and started becoming carbapenem-resistant Enterobacteriaceae. What is Enterobacteriaceae? Enterobacteriaceae is almost all of the big gram-negatives that come from the gut, except Pseudomonas, which is what E. coli, Enterobacter, Klebsiella, Proteus. All of those Enterobacter. All of those called Enterobacteriaceae, and these are the ones that they're morphing very quickly, especially Klebsiella. We call it the KK, killer Klebs, which is resistant to carbapenem. Remind me, if we have a minute at the end, I'll tell you about some experience that we had in a hospital that I know that was actually very informative. Anyway, so carbapenem-resistant Enterobacteriaceae, that's cefdericold is used for that. Okay. Now there is another class. It's called basically like it's another aminoglycoside. So it's like the next generation, I guess, aminoglycosides, and it's called plazomicin, and it's exactly the same. It doesn't have gram-positive though. And CRE. So it does kill the Pseudomonas gram-negative and the CRE. Okay, so if you have CRE, you have two options there to use. Okay, most of the time CRE is also resistant to aminoglycoside, but it's worth checking. You know. Okay, there are three. I'm going to show you another new antibiotic. It's called tigercycline. I'm sure you heard about it, right? Tigercycline. Call it the tiger. Unleash the tiger. Right? So the tigercycline, this is what it kills. I think there's a lot of maybe exaggeration in the tigercycline. There's a lot of studies showing now that it's not really the way we think it is. But this is what it's purported to kill. Are you ready? Pseudomonas, gram-negative, MRSA, gram-positive, and anaerobes, and C. diff. It kills C. diff. What is this?
Patient.
And the patient role.
And the patient.
What the heck? So this is like the class of what? Tetracycline, doxycycline, tigercycline. So that's like the 3rd generation of that class. Tetracycline used to be it used to kill everything. Also, when people in old age, it also kills the teeth, kills the bone, kill everything else. So I don't know. Like this we have no idea. There's some studies now putting some doubt on the C. diff. They say the C. diff was only in vitro, that we don't know for sure, whatever. But I reach out for it sometimes when we have somebody with C. diff, right? I want to tell you one other thing about Zosyn is that, remember we said Vanco, there is some question about where they set the MIC. Zosyn is the same. Zosyn, the MIC is set to be 32. So Vanco is set to be 2, right? For MRSA. MIC for Zosyn is set to be 32. And there is a lot of people talking about there could be a scam or some study issues or whatever, and it should be set at 16. So when I see somebody that is having more than 16 on Zosyn, you'll see that it says sensitive next to it. If this infection is severe and the guy is dying from the infection, I'm probably gonna use carbapenems. Okay, so that's that. Okay, let's talk about the 3 organisms that, to me, they're all the same. They all remind me of each other as if but they have no relation to each other. But they're just like they're all gram-negative. So that's the only relation. Serratia, Acinetobacter, and Stenotrophomonas.
Isn't that Pseudomonas?
It used to be Pseudomonas, and now they had it by itself now. It's a different than Pseudomonas, so it's like the cousin of Pseudomonas, Stenotrophomonas, right? So I'm writing them in the order of weakness. Serratia is weak. It's in the bathrooms and stuff. Serratia, Acinetobacter, and Stenotrophomonas. Stenotrophomonas is bad. Like, and I've never seen Stenotrophomonas coming from the community. I've seen Pseudomonas coming from the community. So Stenotrophomonas, 100%, it's a hospital organism.
Yeah,
And
my understanding is like standing water,
Yes.
like dialysis
Yeah.
patients and condensate and vent tubing, if they haven't changed the filter.
Yep.
Are
And
like,
more importantly, now we know, it's actually, we know from before, but now we proved it. It comes from the pipes. Hospital pipes in general have
Stenotrophomonas.
Stenotrophomonas.
Jeez.
I drink the water from here.
No,
I drink the
no,
water.
We drink Poland Spring.
So just specifically for those, so I put them together with this one can be killed with anything. All right. So this can be killed with anything that kills gram-negative, like ceftriaxone. Okay. Acinetobacter has a specific, a specific antibiotic that kills it, which is sulbactam. This weak antibiotic that you add to penicillin. So the only thing that should be used for Acinetobacter is Unicin. For some reason, like you can give it Zosyn, it doesn't die. You have to give it. It kills it at the end. But the more specific for the organism is Unicin. So once you find Acinetobacter, go for Unicin. Stenotrophomonas, there's only 2 antibiotics that even we test for it: levofloxacin and Bactrim. You can use carbapenem, you can use whatever you want, doesn't kill it. Levofloxacin and Bactrim, 2 antibiotics that I hate, but you have to use them, okay? All right, so let's talk now about antibiotics. Maybe we can write it next to it here so we can make a, right here. Right, so we're going to talk about the antibiotics that kill gram-negatives, but not MRSA. So we're going to write, obviously, not aminoglycoside, we're going to write 3rd generation cephalosporins. Okay? We're going to write 2nd generation cephalosporins. All right, we're gonna write penicillins, carbapenems, some of them, or one of them. And we're gonna write fluoroquinolones, one of them. Right, so 3rd generation cephalosporins, what are the examples here that we can for killing not Pseudomonas, right? So all of those, I'm just gonna, okay. So here we're gonna write that basically what do you call it? Ceftriaxone. Ceftriaxone is a 3rd generation cephalosporin that doesn't kill MRSA, but it's a workhorse. It's amazing. It kills, everybody loves ceftriaxone, and the good thing about ceftriaxone, it's been around since well, how many years ago? 35 years ago, right? And despite being around for all that much, it maintains its sensitivity. It kills everything. Still, nothing is. Look at those organisms here, fluoroquinolones. Fluoroquinolones has been used so much in the 90s and early 2000s that it's lost its power. Now E. coli eats fluoroquinolone for lunch. You still have some activity for Pseudomonas, right? So still you reach out for it for Pseudomonas, but E. coli, irregular E. coli for urine, you put somebody on Cipro or something, it's just like bacteria, just like put it in a sandwich and eat it, right? Right, so that's ceftriaxone, and it does kill the gram negatives and gram positives. How about second generation cephalosporin? We have cefotetan and cefoxitan. These are mainly used by surgeons in the OR if they don't want to cover Pseudomonas. But remind me, I have to tell you about some infections, that some areas not infected by certain things, so MRSA and gram positive. Okay, so basically those cover all of the gram negatives, all of gram positives, and anaerobes as well. So it's good for the bowel and stuff like that. We use it for the bowel. There is also penicillins like Unicin and Augmentin. Pseudomonas, gram negative, MRSA, gram positive. And again, they cover these two, gram positive, gram negative, and anaerobes. That's like Unicin and Augmentin. Okay. Now, carbapenems that cover only, that don't cover MRSA, is the only one left is what? Ertapenem. I found out that some people don't know that ertapenem doesn't cover Pseudomonas. So what's the difference between ertapenem and meropenem? MRSA, Pseudomonas, gram negative, gram positive. What's the difference between ertapenem and meropenem? Is that ertapenem doesn't cover Pseudomonas or Enterococcus for some reason. So the two organisms that are missed is Enterococcus, which is one of the gram positives, and Pseudomonas. So it covers this and anaerobes. So it's a workhorse also. People like it because it's once daily and it can be given IM. This can be given IM too, by the way. So you can use it for patients with UTIs and stuff like that, coming from nursing homes, Klebsiella or whatever, but not Pseudomonas. You can't use it for Pseudomonas. Fluoroquinolone, the only one left that doesn't treat MRSA, doesn't treat Pseudomonas, is what? Is moxifloxacin. Remember that? Used to be very famous in the past. Moxifloxacin. And MRSA, Pseudomonas, gram negative, gram positive. And it does cover gram negative. This is a good antibiotic. I like it. Anaerobes, kills anaerobes as well, so for aspiration pneumonia and atypical. So if you have one of these old ladies coming in, whatever, and is having some pneumonia, and I want to cover atypicals, but I think she's aspirating too. Great organism, a great antibiotic to use it. It can be given PO also, right? And still exists, by the way, in outpatient settings as a recommendation that to be used as I think it's second line or something. All right, so that's that. Okay, so let's talk about other things that kill only gram positives but not MRSA. And I'm gonna just for the interest of time, we're just gonna say we have clindamycin, we have nafcillin, we have oxacillin, we have Ansef, which is first generation cephalosporin. These two are second generation penicillins, and this is clindamycin. This kills anaerobes with it too. These two, this one is great for brain crossing the blood-brain barrier and we get very good concentration in CSF. Oxacillin is also good for that, but it's it's the best one to be used for MSSA bacteremia. Like you have staph but not MRSA in the blood. It's much better than Vanco. So we'll be waiting. We'll be chomping at the bit. We have and here in the lab they have a probe, or used to have a probe that they don't have to wait for days to see if the bacteria dies from whatever. They just put a probe and say it is not MRSA, likely not MRSA. Thank you. If it's not MRSA, then use oxycillin quickly. Like don't wait, because this is a killer. Is a cidal. Ansif does the same. It's also cidal antibiotic. That's why it's used for surgery. All prophylaxis for surgery comes from is done by Ansif for the same reason. So that's MSSA bacteremia. Okay. Now, just quickly in the last minute or so, I'm gonna tell you a couple of things. It's all trivia. May need a whole lecture by itself, these trivias. But anyway, like things that Okay. So for example, Zosyn is bad for CSF. You can't use it for CSF. The one that is great for CSF is ceftriaxone, right? And it's used in a different dose. It's used 2 grams Q12. And with Vanco, both. Ceftriaxone and Vanco, they're double covering pneumococcus, which is the most common organism for meningitis as well, right? These ones here, meropenem and carbapenem, are very good for the CSF. So you can use it if you're worried about Pseudomonas in the CSF, right? But they have a problem. Imipenem decreases seizure threshold. So there's a problem with seizure here. Ertapenem also decreases seizure threshold. Okay, so that's a problem. Meropenem have much less, seizure than both imipenem and ertapenem. So it can be used, still can decrease the seizure threshold, but not as much, right? Okay, so let's talk about, different. So for example, we didn't talk about fungal coverage. Let's quickly say that. So basically, fluconazole. Next step is micafungin or caspofungin. They're both the same, basically. And then voriconazole. And then amphotericin, or we call it amphotericin, and ambisome. Okay? So when I think about fungus, I think about it this way. Candida albicans. And then Candida glabrata. I'm very simplifying this. It's like Candida non-albicans, basically. Glabrata meaning non-albicans, right? And then the yeast Aspergillus, right? Aspergillus here. So if you have Candida albicans, fluconazole is great. People underdose all time. You're supposed to give 800 bolus followed by 400 daily after. Okay, it causes liver dysfunction and stuff like that. If you have Candida non-albicans like glabrata or other things, your go-to is micafungin and caspofungin. If you have anything that has to do with Aspergillus, then you can't use these two. Caspofungin has some activity against Aspergillus, but it's not really the best. You can use voriconazole. And if voriconazole doesn't work, you can use amphotericin. Amphotericin can cause severe illnesses and drop of blood pressure and allergy and stuff like that. So people use now ambisome, which is amphotericin in a lysosome. So it secretes, slowly, not during the infusion, and it can actually very much tolerate it. That's for Aspergillus. One anecdote, some tidbit about voriconazole. Voriconazole IV cannot be used in a renal failure patient. You have to use voriconazole PO because of the solvent. The solvent in voriconazole IV can cause problems in accumulated renal failure patient. You have somebody with renal failure, not on pressors, use voriconazole PO. You have somebody with renal failure on pressors, use ambisome for Aspergillus. And we know how to diagnose Aspergillus. We can talk about infections that can, certain things. So for example, Enterococcus doesn't infect the lung. For some reason, there's no Enterococcus pneumonia. Candida also doesn't infect the lung, unless you're a bone marrow transplant patient, which is like severely immunocompromised. But most of the time, Candida just grows in the lung or whatever. if you have a perforation above the second part of the duodenum, above the ligament of Treitz, they call it, cover candida. You have to give fluconazole for those people because there's a high incidence of candida overgrowth there normally, and if there's a perforation, that makes it to the bowel. This has been debated, but I use it all the time. It's not a big deal. Add a little bit of fluconazole to them. Right? Patients on TPN having infection for a lot, TPN for more than 5 days having a fever, and I can't find where the fever is coming from. Cover with caspofungin and maybe candida non-albicans. It kills candida albicans too, right? Staph can rarely cause UTI by itself. So staph in general, staph aureus or staph, epidermidis or whatever, it shouldn't cause UTI by itself, except rarely if you have a Foley or something. But in general, usually when you see staph in the urine, you have to look where the staph is coming from. It's usually coming from bacteremia and spilling into the urine, right? What else? Yeah, we can stop here. Any questions, professors? With the emphasis on pros.
Professors.
Bro, you're the pros now. You're the pros. No?
No.
All right. Thank you very much. Obviously, there's so many other things, but this is like the basics. This is like